Before I welcome our final plenary session, I'd like to make a few closing remarks and offer some housekeeping notes. But first, I'd like to invite Teresa Anderson from the Urban Institute to come say a few words about the next NARS workshop, and also Russ Sykes from APHSA to make an announcement about the NASTA meeting following this conference.
Hi, everyone. I'm Teresa Anderson from the Urban Institute. As those in the room can appreciate, if I sound nervous, I'm really just cold. But I just want to thank Tiffany McCormick and Emily Schmidt for giving me a minute to speak about another great organization and conference that has been long a friend of RECS, and which many of you may already be familiar, which is the National Association for Welfare Research and Statistics, NARS. For those who aren't familiar with NARS, it's an association, or we're an association of researchers and data professionals that focus on human service programs at the state and local level. Our conferences highlight some of the best research in the human services field, but this year we did transition to a biannual conference schedule which complements RECS, so that our next in-person workshop will be in 2017, with more details about that coming very soon. But in its place, we're not falling off the map this year. We're having a virtual workshop series this summer with monthly webinars in June, July, and August, and we invite all of you to take part in that if you would like. The first one will be a Research Academy webinar on June 29th, so write that down, June 29th. It'll explore both implementation experiences and supports for state and local government to use randomized control trials to test innovative strategies. Mike Fishman from MEF Associates will moderate the session, and you can find more information as it becomes available at our website, nawrs.org. And we encourage everyone here to join us and to invite your colleagues, friends, and neighbors. So I mentioned that website, nars.org. We just this week released a new look for that website, so please come check it out, even if you've been before a while ago. We're trying to make it a more dynamic space with ongoing information exchange, and there's also an opportunity there to sign up for our mailing list. Now, we don't spam you, but if you want to keep up with some of the events around the workshop and other resources in human services, we do encourage you to be part of our community. So I want to thank you so much, and we look forward to seeing you at the 2017 NARS conference. Thanks.
Hi, I'm Russ Sykes, and I'm the director of APHSA's Center for Employment and Economic Wellbeing. And two of our major affiliate partners, the National Association of State TANF Administrators and the American Association of SNAP Directors, are intimately involved with the center. But what I really wanted to announce very simply today is that after this meeting, at 1 o'clock in the Palladian room, anyone who's a TANF director, there will be a meeting of the National Association, a brief meeting of the National Association of State TANF Administrators, mostly to focus on planning our joint conference in October with the SNAP directors and the TANF directors in Orlando. We're working hard on an agenda. There will be a lot of research flavor and practitioner flavor. And so 1 o'clock in the Palladian, for anyone who's here, I know Todd Bland, who is from California and chairs our National Association of State TANF Administrators, is here, and I thank Tiffany very much for letting us have just a brief moment to remind people about that. Thanks.
Great, thank you both. Before I invite our plenary panelists to come to the stage, I'd like to take a moment to thank all of you, both those who are present in this room and those of you who have joined us virtually, for your attendance at the 18th Research and Evaluation Conference on Self-Sufficiency. I hope that you have enjoyed the last 2 days of productive conversation and networking. What is so unique about this gathering is the opportunity to bring a diverse group of researchers, practitioners, and policymakers together to discuss cutting-edge research in family, self-sufficiency, and social welfare programs and policies. As Deputy Assistant Secretary Naomi Goldstein mentioned in her opening remarks earlier this week, the conference has experienced many changes since we last met in 2014. We have since rebranded our conference and moved to a biennial schedule, so I have the privilege of saying we look forward to seeing you at the 2018 RECS. Part of our motivation for moving to this schedule was so that we could have more time to prepare for the conference and continue to select the highest quality research. The number and caliber of proposals received this year in our call for proposals and diversity sessions we were able to feature at this year's conference did not disappoint. We held more sessions this year than we have in previous years, and a record number of individuals registered for this year's conference. It's impossible to tell what the 2018 conference will look like at this point, but if this year's conference was any indication, I am certain it will be just as stimulating and insightful. After this morning's plenary session on replicating evidence-based social programs, we will feature one more series of breakout sessions starting at 11:45 a.m. I'd like to say that we've saved the best for last, but I hope that everything you've seen has been engaging and thought-provoking. We have some wonderful sessions to close out the conference, including findings from the Work Support Strategies evaluation, an overview of new approaches to support youth who are homeless, and several others, and I hope that you will attend one of them. A few housekeeping points before we move on to our plenary session. First, the conference evaluation is available online, and on Monday you should receive a link to complete the evaluation in your inbox. We really do take your feedback seriously, so I hope that you will take the time to let us know your thoughts. Conference presentations are available by request, and you can still access them on the app if you've downloaded it. We really, are willing to make the conference presentations available if we do have them, so please see in your program books, there's an email address, or you can see our website for how you can request those. Videos of live stream sessions will be available online on our website later this summer, so please continue to check back on that. And finally, we hope that you will continue to stay connected with us via social media. On the back of your program book, you can see a variety of ways to keep in touch with us on LinkedIn and Twitter. You can also join the OPRE listserv and visiting the RECS and OPRE websites. Finally, 3 last thank yous are very well deserved. First, to the Omni Shoreham hotel staff. They've done an excellent job taking care of us this week and making this a very enjoyable conference. So we thank all the staff. Second, our AV and live stream techs are seated at the back of this room, and they've done an incredible job behind the scenes to make sure everything runs smoothly. A special thanks goes to our AV techs, Anthony, Faterel, and Torian, and also the live stream team with flying colors. Thank you very much. And lastly, we'd like to thank our logistics contractor for this conference, Impact International. They've done an amazing job at coordinating this conference and making sure we knew where we were going and when. We were very grateful for their expert assistance with all of the conference logistics, and we couldn't have done this without them. And so with that, I'd like to invite our panelists for the Replications of Evidence-Based Programs plenary to the stage, including our session moderator, Seth Chamberlain. Seth is the Adolescent Development Research Team Leader at ACF's Office of Planning, Research, and Evaluation. He manages research and evaluation projects focused on a range of youth, family formation, and family functioning issues, including adolescent pregnancy prevention, healthy marriage, responsible fatherhood, and domestic violence. His portfolio also includes issues related to low-income and at-risk lesbian, gay, bisexual, and transgender populations. He has a particular interest in healthy adolescent development and successful transition to adulthood. Prior to joining OPRE, Seth taught middle school Spanish in Chicago, interned at a program for men convicted of domestic battery, and interned as a clinical social worker at the University of Chicago Hospital. He holds a BA from Goshen College and an AM from the University of Chicago School of Social Service Administration. Thank you.
Hi. So I'm just going to introduce the speakers briefly, and then I'm going to sit down and shut up. So our first speaker is Matthew Klein. He is the Executive Director of the Center for Economic Opportunity and the Senior Advisor for Service Innovation in the New York City Mayor's Office of Operations, where CEO is housed. Mr. Klein oversees a portfolio of cross-agency initiatives focused on developing citywide measures for opportunity and equality, bringing effective anti-poverty approaches to scale, and using technology and data to enhance the delivery of social services. Next, Meredith Kelsey will speak. She is a principal associate at Apt Associates. She has more than 15 years of experience working with programs and policies for youth, including youth development programs, abstinence education programs, sexuality education programs, and other programs that serve teenage and young mothers. Lastly, Amy Margolis will speak. She is the director of the Division of Program Development and Operations in the Office of Adolescent Health at the U.S. Department of Health and Human Services. And she is the lead for the office's National Evidence-Based Teen Pregnancy Prevention Program. At OAH, Ms. Margolis is responsible for developing programmatic and policy guidance, monitoring program implementation, overseeing training and technical assistance for grantees, and communicating lessons learned and program successes. Our discussant is none other than Naomi Goldstein, who you all know is the Administration for Children and Families Deputy Assistant Secretary for Planning, Research, and Evaluation. Naomi has not only pushed our office towards excellence, her leadership, I'm sure we would all agree, has pushed the field of social services research towards excellence, and she's kind to boot. If you want to know more about any of us, you can look in your app, and all of our bios are there. So with that, I'll turn it over to Matthew.
Is there a clicker for the, is there a clicker for the?
I believe it's right here.
Okay, great. Great. Hi, folks. Well, it's a pleasure to be here. It's a pleasure to represent New York City and the Center for Economic Opportunity, or CEO for short. I'm going to spend my time talking a little bit about the local perspective of city government and how we're trying to use evaluation as a tool to advance our efforts, particularly against poverty. First, and also in doing that, I'm going to touch on three distinct models, places where we've made particular investments based on evaluation and how we've done that in different ways. And then I hope during the course of that to be touching on items that are more broadly applicable and generalizable from our experience in New York City. So quick background on CEO. Our mission in New York City is to help our local government reduce poverty and broaden opportunity. And we do it by utilizing evidence, both in the development of programs and policies, in the delivery of services, and most importantly, in the decisions that we make around our budget and expenditures. We're founded in 2006 as a discrete unit within the mayor's office, which I'll touch on is important for bureaucratic reasons and helpful when trying to use evidence to drive decision-making. And while our work has been evolving, there's three large strands. One is around poverty research. We have a unit, we have a team within the unit that essentially does a supplemental poverty measure for New York City locally. In fact, it preceded the official supplemental measure. And that allows us to draw on localized data to shape policy, to look at trends within groups, within neighborhoods, and to have a more sophisticated understanding of whether our policies are moving the needle one way or another. We started as an innovation fund with a particular mandate to create new pilot demonstrations, building on evidence that existed elsewhere and sometimes trying brand new things, and to test them rigorously, grow what works and end what doesn't. We still do that design work of new, unique models or models that build on evidence outside of New York City. But increasingly, we're applying the evidence lens beyond the portfolio of pilot organizations to the core funding that the city deploys across its, its $80 billion budget. A large percentage of that is going to social human services. And we do that principally through serving as an evaluation resource for the city. We maintain an open contract with 8 evaluation firms. I think many, if not all, are represented here at the conference, including APT, MDRC, Urban Institute, and others, allowing us as a government entity to quickly partner with expertise focusing on a range of different questions depending on what's at hand. Just very briefly, the mechanics, because I also think it has broader implications. Funding flows to CEO from our budget office based on mayoral priorities and interest areas. We partner with our local agencies. Funding is then released through RFPs to nonprofits who are doing the delivery of the service. And so that has 2 important implications, I think. One is just we can't underestimate the impact of government's relationship with nonprofits. We know that implementation matters. We know that models don't run themselves. And there's an increasingly active conversation between government and our nonprofit sector partners about whether the structural ways that we engage with them is conducive to them having success. And similarly, by working closely with agency partners, but also having a discrete budgetary authority, we can bring heightened accountability to the ongoing delivery of services. So hopefully that leads to a quicker feedback loop when things are, when programs are not achieving the results that we hope for, or we're uncovering problems, we can hopefully help before waiting for a period of time and only doing a backwards look and see whether or not work was effective. So we do evaluations in the way that will be familiar to the folks in this room. We look at, on the early side, focusing on implementation often, capturing best practices, helping our nonprofit partners ramp up, learn how to deliver evidence-based models. We do outcome studies, impact evaluations, increasingly more attention on return on investment and looking at the cost per outcomes and not just the cost per participants. And we use all of that information to inform the work that we do, again, in familiar ways to all of you, but sometimes unusual in the local government in an ongoing way, to inform program design, to evolve program models so that we're not just a up-down, yes, no, this worked, it didn't work, but we try to tease out what's being effective in a particular model and what isn't. To shape the way that city then goes out, that city procures new services so that we can embed good practice and evidence-based principles. And ultimately, of course, to decide whether or not to discontinue initiatives or make substantial investments in ones that are showing promise. And so I want to talk just briefly, again, touching on 3 different discrete models and ways that that's played out on the ground. One is in relationship to Jobs Plus, a program model that many of you may know that's an employment place-based approach, focusing on public housing and blending in New York City 3 elements. One, job training or job search support, financial incentives in the form of rent disallowances so that as folks make more money, they don't necessarily pay more rent in public housing, and community support for work, which entails training residents to engage with neighbors, helping them become aware of the services of Job Plus, and with the goal of saturating a particular public housing development with the notion that there are resources for support and there are people and neighbors who are focused on resident success. In this case, we built on evidence that was developed out of a separate demonstration program funded by HUD, analyzed by MDRC, and decided to try it out in New York City. We began with 1 site and have subsequently expanded it in New York City to now be in 8 locations. And interestingly, have, I think, helped HUD see the potential value, and they've launched a new demonstration that's now funding 18 Jobs Plus sites around the country. So it's been an interesting evolution from a demonstration model, use of evidence, locally, and then now back to a national model. And here, again, a big takeaway for us has been about the implementation and how that matters. It was in the debate between, do you just deploy a model with fidelity versus do you take principles? We're trying to walk the middle line here. Our providers had playbooks and guidebooks, thinking about what milestones and metrics and principles were manifest in the success of the early demonstration, but they developed those on their own, and we're also seeing sort of what the early startup stage challenges are. So we're continuing to study the model on an implementation of the new sites that have expanded, and are beginning to also focus more intensely on looking at what the job outcomes are of residents. We found initially that folks were being placed into jobs by the hundreds, but the jobs were often low wage, and so we're going to do a match comparison study of folks who participate in Jobs Plus and folks who are residents of the communities but aren't participating in Jobs Plus. So that was a model of replicating a particular, or that was an example of replicating a particular model. We also had, I also want to highlight an example where we had a homegrown model that proved posted dramatically impressive gains and has led in New York City to a very substantial scaling of a model. And this one is the Cuny Accelerated Study and Associates Programs, or ASAP for short, which has as its intention to speed the path for students in community college seeking associate's degree to earn those degrees and to increase the graduation rate within 3 years. We've done a 5-year experimental design random assignment study. We've done ROI studies. We've looked at implementation. And the results have been significant. ASAP has doubled the 3-year graduation rate of associate degree students from about 20% to about 40%. That's garnered a lot of attention from our mayor, who committed the resources to move from what started as an original cohort of 1,000 students to what will be 25,000 students by the end of 2019. It's led one of the colleges in the Cuny system to move to 100% ASAP model. It's had one of the lowest graduation rates and is aiming to boost that to what ASAP has achieved in other areas. And then we're seeing replications elsewhere in a 4-year college and in Ohio. So there'll be plenty of opportunity with ASAP, I think, to look and study what the effects are for a replicated model. And then the last example I'd highlight is a place where, building on evidence, we've sought to infuse the principles of what we think was driving success to help inform broad system change within New York City. So here the model was sector-based career training. New York City had a number, like all cities, of workforce centers to provide a broad range of services to job seekers. And based on evidence, again, from an earlier study that showed that sector-based training produced better results than just general job search support, New York City opened a single sector-based model. And then over time found that sector-based training and that sector-based career center led to higher earnings, higher placements, and better success relative to the more generalized workforce supports. And again, and that has led us in a broad system review of our workforce to invest more heavily in the intermediaries that do sector-based training. So moving from what was 2 then 3 sector-based intermediaries to 3 or to 6, to thinking about how we can reallocate our dollars across all of our workforce funding to invest more in industry-specific training, and then recognizing that some folks need earlier help, basic skills help, before being qualified for industry-specific training, to invest more in bridge. So here we're not necessarily replicating a specific model, but we've taken examples of models and infused the principles of those successes into a system that spends upwards of $500 million a year in New York City. So broad takeaways from that for us in New York City as we kind of continue to build our toolkit of using evaluation. First, I think like many of the themes in this conference, we need to do a better, more active job of using our administrative data. So we are committed to the rigor of our scientific studies, value our partnership with our research firms, but we know that we need sort of a, as close to real-time signaling as we can get around whether we're on the right track, including of models that have had a successful implementation. So, for example, with ASAP, even though it's much studied and lauded, quarterly we're looking at the progress for the expansion. We're looking at enrollments, persistence. We're looking at the impact of particular majors, particularly around STEM. So, we're doing our best to walk the walk of not doing the one-time evaluation and saying it worked and assuming it'll work forevermore, but embedding into our ongoing practice and management the use of administrative data. One example of that on the workforce is to do the hard work within our city of zeroing in and defining metrics in common ways. So it's been very difficult to understand across different program areas, different funding streams, different models, different providers, whether organization A is doing a better job of placing folks than organization B, or program model A is doing better than program model B, because even though people might use the same words, job, placement, retention, the definitions in each of those models might be different. So we spent about a year working across our agencies in New York City to align on just the definitions of those words, and now have a commitment so that any funding stream that goes out when they use particular words have to mean the same things, allowing us to do a better job to leverage administrative data in an ongoing way. I think we need to build our capacity, build our nonprofit capacities. We need to do more on a broad scale to integrate the use of evidence and analysis of evidence in our budgetary decisions. CEO was founded with a mandate to do that for our portfolio of programs, but as I mentioned, we're expanding to apply a evidence-based lens and evaluation support services across the range of funding. We need to be more sophisticated around embedding that evidence lens in budget decisions across the board. And I think, frankly, cities need more tools to be able to do that. We can look at and see what the program models are that we're implementing, but the balance between sort of a fast cut, yes, this applies some evidence-based practices, how much fidelity are there, what is the relative populations that are being served, tools and frameworks to allow us to look at existing programs across a budget and have some guidance without doing a full-on study are things that I think we as practitioners need, and encourage the field to move to developing and supporting more tools to help us do that. And then lastly, we need to do more to do fast RCTs. We have a partnership with Ideas 42 where they're embedded within our office, the Mayor's Office of Operations, to help us on design and infuse some of our practices with behavioral insights. And those practices, small tweaks to the way we communicate with residents, the letters, the practices of frontline staff, allow us to make fast tweaks and nevertheless use the rigor of a RCT to know whether or not those tweaks are making a meaningful difference or not. I'll end there. I apologize if I went a little long. Our website has the studies that I've talked about, and I hope I've left you with a sense that we are committed to continuing to apply evidence in the most rigorous way possible in our fight against poverty and inequality in New York City. So thank you.
Hi, Thanks very much. I'm Meredith Kelsey. I'm the project director for the Teen Pregnancy Prevention Replication Study. And this is a project that's funded by the Office of Adolescent Health and the Office of the Assistant Secretary for Planning and Evaluation. We have a couple project partners working with us on this, including Decision Information Resources and Belmont Research Associates. So I thought I would start with a quick background on the teen pregnancy prevention program. So to sort of situate it, I know this is a panel on replicating evidence-based programs, but to sort of give you the context for where this particular study fits within all the other efforts. I'll then talk a little bit about the study design, the models selected. I'm going to focus on the short-term findings today, and then also we'll have a little bit of a discussion. I should say I'm actually going to try and cram 3 different studies into this one sort of overall presentation. So this is all at a pretty high level, and I'll move pretty quickly, but I'm certainly happy to take additional questions at the end if there's time. So in 2010, there was a new teen pregnancy prevention program that was created along with the Office of Adolescent Health, and it was really what is now referred to as a tiered funding program, in which there were funding to support replications of evidence-based programs, as well as to support research and demonstration programs, which were at the time untested. Both of these funding streams had required program performance measures, as well as evaluation requirements at the grantee level. And then for the replication pot of money, there were requirements for local evaluations for grants that were actually larger in size. So for a subset of the existing evidence-based program models, there was a requirement that they do an evaluation as well. And Amy Margolis, I think, will give a little bit more context for sort of the pool of evidence-based programs and how that was created and what people could select to implement. And then finally, for both the replication programs as well as the research and demonstration grants, there are other additional federal studies. So the study that I'm focusing on is the replication study, which is associated most directly with the set of programs that were funded under that first box. So the primary objective of the replication study was really to add to the existing body of evidence and to generate new findings on a subset of the set of programs that were being implemented or replicated by grantees. And so we're really focusing on a specific select number of program models that had some evidence prior to this, but really sort of now this is taking it a step further to look at whether these programs are replicated and are they effective in different places and with different populations. Another goal of the study is really to complement the grantee-led evaluations by producing evidence about the effectiveness of program models as opposed to a single-site replication that actually is more generalizable than some of the single-site replications. And again, the idea was really to add value because there's as you see and you'll hear from Amy, there's a lot of evaluation efforts happening, and so the purpose was really to find value for this specific evaluation. And also, the study will allow us to examine the pathways that lead to behavioral outcomes, and because we're looking at, we specifically chose to focus on 3 program models, and within the models we have 3 replications of each. So we're actually looking at 9 individual site-level replications, but we're always reporting it we're looking at 3 program models. So by looking at 3 program models, we're going to look at whether it's possible to replicate these programs consistently and with fidelity. So what does it take to produce a strong implementation? And really this first question is an implementation question that's addressed primarily through an implementation study that's actually part of this evaluation. And the second question is really looking at the program impacts on behaviors, on sexual risk-taking behaviors, as well as intermediate outcomes that are thought to be related to sexual risk-taking behaviors. And again, this study is really going to go beyond the evidence, the existing evidence, and the evidence it complements the evidence that's being generated from the site-level studies. And because we're looking at pooled analyses, we're also able to do subgroup analyses that may or may not have been able to be done at the individual site-level evaluation. So I will quickly go through the program model so you have some sense of what we looked at. And I will say, we selected these program models in part to, at the time that the study was designed, in part to address some of the gaps that had been identified in the existing literature. And we also wanted to provide evidence. At the time that these programs were in 2010, there was really limited evidence. Most of the programs that were eligible for being implemented were really based, the evidence was really based on a single study in many cases, and so there was pretty limited evidence. So we really wanted to select program models that represented different strategies to intervene, as well as filling gaps in the existing research. And so the other thing for the first program we selected was Cuídate, which is an HIV/AIDS prevention curriculum that's culturally tailored for Latino youth. It includes 6 one-hour sessions delivered in small groups. The sites they were selected from the pool of grantees who were implementing Cuídate and who could support the requirements of participating in a rigorous evaluation. And finally, each of the program models, each of the 3 grantees listed here chose to make minor adaptations to the program that were approved at the outset by the Office of Adolescent Health, and these tended to include adding 1 additional session on pregnancy prevention and HIV/STDs. The second program model is Reducing the Risk. This is a sexual health and risk prevention curriculum that consists of 16 sessions. It was delivered in school settings in each of the 3 sites listed here. And in each site, the program was offered during in-school class time. Again, the sites were selected from the pool of grantees that were implementing Reducing the Risk and could support the evaluation requirements. And at the time, when we were selecting programs, we really did try and find models that had multiple replications so that we had a good selection. And so I think the minimum, when we were thinking about this, the minimum that we were looking at were program models that were being implemented by at least 5 grantees. So we sort of started with that as one of our criteria. And then the third program is the Safer Sex Intervention, or SSI. And this is a clinic-based program designed to be delivered in clinic settings for female adolescents ages 13 to 19. The intervention consists of 4 sessions that are delivered face-to-face with a health educator trained in motivational interviewing. And each of the sites here, this is probably the closest, this is, if you wanted to look at what happens with a different population, in this particular model, each of the grantees that were implementing the program chose to implement the program with sexually active young women or women who are contemplating becoming sexually active and coming into a reproductive health clinic. This is the one that's probably farthest from the original study population. Okay. So our research questions that are sort of part of the impact study, so for each of the program models, so for the 3 program models, we're looking at the program impacts on sexual behavior, teen pregnancies, teen births, and STIs. We're also looking at the program impacts on the non-behavioral outcomes that are theorized to be related to sexual behavior, such as attitudes, motivation, knowledge, and skills. And finally, we're looking at whether impacts differ by site and by specific subgroups of interest, including gender, age, ethnicity, and sexual experience at baseline. So in each of the 9 replication sites, the design includes 2 randomly assigned groups. So there's a treatment group that receives the intervention and a control group that does not. The data are pooled within each program model, and the impacts are estimated and reported separately for each model. For each of the models, we do have a short-term report, which is roughly 6 to 12 months after the study enrollment, and then a long-term or final report that is looking at program impacts 18 to 24 months after study enrollment. And again, the discussion here, we're really focused on the short-term findings. And the report, I should say, is not yet available. It will be soon. So what I'll do, as you'll see, the results are really presented sort of a summary of where we found findings, and the specifics will be available soon. So quickly, the surveys. Again, this is something that seems at least to me anyway, pretty unique in that the surveys included a common set of measures across studies. So they included the program performance measures, which were asked by all of the grantees. So the measures are consistent across the federal studies and across the local, the grantee-led evaluations. And then it also has additional questions on other behaviors and intermediate outcomes. The surveys were administered through a web-based audio CASI system, which meant that participants had the option of having the survey questions read to them if they needed. And so for the short-term analysis, we're really focused specifically on the intermediate outcomes, what we're calling the knowledge, attitude, skills, motivation, and attention, and then sexual risk behaviors. Those include engaging in sexual activity and use of condoms and contraception. The longer-term report is when we'll be looking at the program effects on teen pregnancies, births, and STIs. We'll also, for the long-term report, we do intend to do a mediator analysis that will then look at the extent to which some of these median outcomes ultimately are related to behaviors. So the first question that we were interested in looking at was whether the programs were successfully implemented with fidelity. And I will say that the Office of Adolescent Health did an amazing thing by requiring grantees to implement the program models with fidelity and requiring them to report on attendance as well as to track and report program implementation and activities through fidelity checklists that were created by the developer. In this way, they really ensured that the programs were being implemented as designed and consistently implemented. And I think, I think Amy's going to talk a little bit about the progression of sort of what the next cohort of grantees looks like. But at the time, this was really unique because I certainly think that our experiences in working with grantees was there were a lot of requirements placed on them with very little room for, they, in some ways felt a little bit straitjacketed. They were held to implement the program model as intended without making major adaptations that would deviate from the program model. And it's really, it's really the first step if you think about, it gives us confidence when I say that here's the impact of the safer sex intervention or reducing the risk. I know exactly what it looked like and what they did, and I can tell based on those performance measures. And I think grantees really took the requirements seriously as well. So the Office of Adolescent Health also provided significant supports for grantees through, not just through the performance measure requirements, but also through monitoring, the trainings that they offered and the support. And then the grantees used the fidelity checklists and the program observations for program monitoring and assessment. And it was a really large and significant investment, both on the part of the program office as well as the individual grantees. So at this point, sort of as part of the implementation study, we can actually say that the programs were implemented with fidelity. In all but one of the 9 sites, grantees were able to ensure that a majority of participants received at least 75% of the intervention. So quickly, before I get to the results, I'm just going to quickly give you some sense of who was served by these programs and sort of what the who got the program. So you'll see that for in terms of gender, both for Cuny and reducing the risk, roughly 50% of the sample was male and 50% were female. The safer sex intervention by design was serving only females. For race ethnicity, Cuny, again by design, was intended to serve a majority of Hispanic youth. Reducing the risk and SSI were more diverse. Reducing the risk, nearly half the participants were Hispanic, and in both reducing the risk and SSI, 1/3 were black. And for age, you can see reducing the risk and Cuny were serving youth who are on average 14 years of age, roughly, at the time of program entry. And although the eligibility criteria for SSI was 13 through 20, the programs ultimately served youth who are slightly older with an average age of 17 years. In terms of baseline levels of sexual behavior, a large portion of youth in Cuny and reducing the risk were not engaging in sexual activity, partly a function of age. Less than 25% of youth in these 2 program models reported engaging in sexual behaviors in the 90 days prior to the baseline. But by contrast, sort of a majority of SSI participants were engaging in sexual behaviors. In terms of sexual risk, so risk of pregnancy, most participants, again, in Quidite and reducing the risk were not at risk of pregnancy, meaning that participants were either sexually inexperienced or had not engaged in sexual intercourse in the 90 days prior to the baseline survey. A greater proportion of SSI participants were at some risk of pregnancy, and nearly a third of participants were at high risk, meaning that participants reported engaging in sexual intercourse without using birth control or a condom. And for risk of infection, the story is roughly the same for Quidite and reducing the risk in terms of the risk of STIs. However, again, I think the contrast to the earlier slide is that for SSI, a large number of participants reported engaging in sexual activity without using condoms, so putting them at high risk for STIs. Okay, so now, again, this is summary level, and I hope this is clear, but I'll quickly talk about the impacts. So these are for the intermediate outcomes, so these are the attitudes, knowledge, intentions, skills, and motivation. Sort of in summary, across the three models, there were program effects on some of the intermediate outcomes. Quidite and reducing the risk had positive program effects on knowledge of pregnancy risk and knowledge of STI risk. Probably in contrast, there were no program effects on these intermediate outcomes for SSI, where baseline levels of knowledge were high for both the treatment and control groups. They specifically, again, targeted youth who were young women who were coming into the clinic. They were most of them were already sexually active, and the baseline levels of knowledge were much higher. Quidite and reducing the risk were on average less risky, so they knew less at baseline. There were effects on skills for both Quidite and SSI. It's a little bit surprising that there were not program effects on skills for reducing the risk, given that this was one of the program, a big program emphasis. For all three models, there were positive program effects on attitudes towards birth control and condoms. And I'll say SSI is the only program in which there was a positive program impact on intentions to use birth control or condoms if they were to engage in sexual intercourse. And this arguably is consistent a little bit with the program theory in terms of they were really trying to get young women. Was a big focus for them. And then because of the pooled design, we were able to test for subgroup differences, and there were some subgroup differences. Again, they're a little bit scattered, so it's a little bit hard to make sense of all of this sort of with all three combined. But you know, these intermediate outcomes, these were all exploratory analysis, and they're really important to look at in the extent to which they ultimately predict behavior. And then for the behavioral outcomes, so overall, across the three models, there were no impacts on sexual initiation or recent sexual activity. However, there were program effects, significant positive program impacts for at least one program model. The safer sex intervention was successful in impacting behavior. And then for reducing the risk in Quidite, there were no findings overall on behavior. There was one significant program impact on sexual intercourse in the last 90 days for the St. Louis site. And then in terms of subgroups, again, all exploratory, but there were differences. There were no differences by subgroup for reducing the risk. There were differences by subgroup for the safer sex intervention positive program impacts. There were actually adverse program impacts for Quidite for certain subgroups, specifically for white youth and for youth who were sexually experienced at baseline. And then finally, the findings here represent the first, these are, again, the first set of findings for three program models. We think that results show it's possible to replicate programs with fidelity and achieve a strong implementation. Again, the performance measure data indicate that the interventions were delivered as intended and that many participants received 75% or more of the intervention. Again, I think across the board, there were very few positive program effects on behaviors. The fact that 2 of the 3 had no overall effect on behavior. There was one site level impact for reducing the risk. It's interesting, particularly given that it was a higher risk population, but this and the other subgroup findings at this point are all exploratory. The exception being the safer sex intervention, which was successful in reducing risky sexual behavior for the overall sample. And this, I think, goes beyond the original study findings in that it actually reduced the incidence of behaviors that almost certainly lead to pregnancy or potentially STIs. And again, the final analyses will provide more conclusive evidence of effectiveness on these particular outcomes, as well as the addition of other outcomes that are particularly relevant to the overall teen pregnancy prevention program, and we'll have additional opportunity to explore the subgroup and site level differences as well. So I'm going to stop there. Thank you so much.
Hi, everyone. I'm Amy Margolis. I am the Director of the Division of Program Development and Operations at the Office of Adolescent Health. And while the slides come up, I'm going to be talking to you today about the findings from the Office of Adolescent Health's Teen Pregnancy Prevention Program and how we've used them to create a culture of learning to inform our program. Before I get started, I did just want to say we received really exciting news from the CDC just a couple of days ago, maybe even yesterday. They released the preliminary teen birth rate data for 2015, and we know the teen birth rate has been going down. We've seen historic declines over time, but from 2014 to 2015, it has gone down another 8%. So we're very excited about that. That kind of keeps us going. So I just wanted to kind of plug for that. And how do I do the next slide? Waiting for the slides to come up. While they're coming up, what I'm going to talk to you about today is I'm going to give you a little bit of an overview of the Teen Pregnancy Prevention Program. Do I need to do it? No, there we go. I'm going to give an overview of the Teen Pregnancy Prevention Program just as background, talk a little about the results and successes and lessons learned from the program to date, and then talk about how OAH uses data and evaluation findings to inform the program. Meredith had already talked about a little bit of this, but the Teen Pregnancy Prevention Program at OAH is a two-tiered evidence initiative. The majority of our funding, approximately $70 million annually, is to replicate evidence-based programs. And for us, those are programs that have been identified by the HHS TPP Evidence Review as having evidence of effectiveness. A smaller amount of money, approximately $24 million a year, is for research and demonstration projects to develop and test new and innovative approaches. We refer to that as Tier 2. So I might slip into Tier 1 and Tier 2 so you know what that means. And just a little bit of history, the Office of Adolescent Health and the Teen Pregnancy Prevention Program were both created in 2010. That was the same year that the HHS TPP Evidence Review conducted its first review and released its findings. At the time in 2010, the Evidence Review identified 28 programs that were considered evidence-based teen pregnancy prevention programs. And those were the programs that our first cohort of grantees implemented. Not all of them, but some of them. We also in 2010 provided our funding to our first cohort of grantees, and we'll talk about that. And then between 2011 and 2014, I think the key point is just that the evidence review is continuously updated, so it's not a static review. About every year and a half, HHS releases updates to the evidence review. By the end of 2014, 37 different programs had been identified. And then where we're at now in 2015, 2016, our first cohort of grantees completed their 5-year grant period in August of 2015. We funded a new cohort of grantees in July of 2015, and the HHS Evidence Review also released another update to the Evidence Review, and we've now identified 44 different programs that are considered evidence-based teen pregnancy prevention programs. And we are planning to release results from 41 evaluations we supported with our first cohort of grantees actually next week. This is just a little on who we serve. The Teen Pregnancy Prevention Program at OAH is a competitive grant program, so we really are focused on trying to reach the communities across the country with the greatest need and the most vulnerable youth within those communities. And so, like I said, we've had 2 cohorts of grantees since our program started in 2010. The first cohort, we funded 102 grantees who served 500,000 youth in 39 states and DC between September of 2010 and August of 2015. And then we're working now with our second cohort of grantees. They started in July of 2015 for a 5-year period, 84 grantees who we anticipate will more than double the number of youth that we're able to serve and reach 1.2 million youth by 2020. A little on the success of the OAH Teen Pregnancy Prevention Program to date, and this is really our first 5 years, so our first cohort. Like I said, our grantees served 500,000 youth in 39 states and DC in the first 5 years. Most of the youth were younger, and then very diverse in terms of race and ethnicity. In addition to the reach and the number of youth, our grantees also trained over 6,100 new facilitators and established more than 3,800 community partnerships. And then, like Meredith had said, we had a strong focus on measuring implementation, quality and fidelity, and also dosage. And so We know from our data 95% of all sessions were implemented as intended, which was our measure of fidelity. 92% of sessions were implemented with high quality, and this data is from independent observations of the program, so we required our grantees to have independent observations of at least 10% of all of the sessions that were implemented. So we're really proud of those numbers. We also know from our data that youth attendance was high, that on average youth attended 86% of all sessions, and this did fluctuate over time and was an area where the data really were used to make improvements over time to the program to boost attendance. And then we have a focus on disseminating the results from the program. So far, 66 manuscripts and close to 1,300 presentations. In addition to our programmatic success, we have had and continue to have a really strong emphasis on investing in evaluation. And so overall in our first cohort, we funded 41 different evaluations across Tier 1 and Tier 2. This slide is really just focused on those that were evaluations of evidence-based programs. Meredith just talked about the Tpp Replication Study, which was the contract supported by our office with the Assistant Secretary of Planning and Evaluation and implemented by APT, where they evaluated the implementation of 3 evidence-based programs like Meredith just talked about. In addition to that study, we supported 16 grantee-led evaluations. These were independent, rigorous evaluations designed to meet the evidence review standards for a moderate or high rating. And across those 16 evaluations, the grantees evaluated implementation of 9 different evidence-based programs in different settings and with different populations. So it's really important that they were taking programs that had demonstrated evidence of effectiveness somewhere and testing them somewhere else. And so overall, between the replication study and the grantee evaluations, it was 19 different evaluations of 10 different evidence-based programs. The numbers don't sort of add up clearly on this slide. And our results showed that we were able to demonstrate that 4 of the 10 evidence-based programs were effective in different settings and with different populations. We're really proud of that, but we also think we've learned a ton, both from where the programs were able to demonstrate positive outcomes, but where we didn't find any outcomes. And they weren't negative, we just didn't find any outcomes one way or the other. Because that is building, for us, the purpose of this was to build a body of evidence. And we think we have built a body of evidence for these 10 programs to really provide more information about where, when, and with whom they're most effective. And that's important for communities to know as they're trying to make decisions of which programs to select that would be the best fit for their community. Some of our lessons learned from the program that will be important when we talk about how we've redesigned the program from these lessons. We really think that the results show we need to build a body of evidence for programs to know really when, where, and with whom they're most effective. Most of the programs identified by the TPP Evidence Review had a single study backing them in the beginning, and so through these evaluations and then other evaluations that have been going on in the field, we're really starting to build a body of evidence for programs, and we're seeing that that's really important to help communities make good decisions. We also think independent replication evaluation is critical. Again, a lot of the evaluations that originally make the evidence review are done by the program developer, so really adding some independence to the evaluations has been important. And we think our findings show that not all programs really can be implemented anywhere, with anyone with the same results. Some programs can, and with confidence, and then others maybe are going to be effective for a more targeted population or a specific setting and not able to kind of be replicated everywhere. And then programs that were effective at one point in time may no longer be effective at a later point in time. Our evidence review spans 20 years. And especially when you're working with youth, 20 years is a long time. So a program that was effective 20 years ago, really may not any longer be effective with today's youth. And so it's important to continue evaluation, to continue making sure programs are engaging and relevant to youth, and not just assume sort of something that showed effectiveness at one point in time is going to be effective forever. And then also how programs are implemented impacts who receives the program and also the outcomes. We hear a lot from our program developers that programs can be implemented lots of different ways. For example, one program can be implemented in 8 hours on a single Saturday versus 1 hour a week over 8 weeks. And we found that's true. We can implement programs in those ways, but the kids that show up change. So kids who can come for 8 hours on a Saturday are different than kids who can come once a week when the program's offered in school. And that's really important and does determine sort of what outcomes you're going to see because it changes who you're serving. And then also dosage is really critical. I think we all know that. We did see that from our evaluations. And training and technical assistance and performance measures are really important to and essential to ensuring quality and rigor, both in terms of programming and evaluation. Just a few final lessons learned. We found more time and emphasis really needs to be spent on program selection and fit and implementation. So really taking the time to do a thorough needs assessment and make sure that the programs that are selected to implement are the best fit for the community and the population you're serving, rather than just programs that the organization has always done or has already purchased materials for or has already gotten trained, but making sure the programs are the best fit. And then using evaluation results to inform program selection can be difficult, has been difficult for our grantees. It means that you need to be willing, in some cases, to move away from programs that are no longer effective, even though you've always done them, or to move away from programs that really aren't the best fit for your community, even though you've always done them. And to be able to do that, it can be really difficult. So I'm going to shift there. That's kind of the overview of results and successes and lessons learned, and I want to spend some time talking about how we've used data and evaluation results to really inform the teen pregnancy prevention program at OAH. And there's at least 4 ways that we've done that. One is we've used our data to identify areas for continuous quality improvement, both at the OAH level, but also with our grantees. We've also used the evaluation results to inform grantee selection of evidence-based programs. We've used the lessons learned from our first cohort to redesign the program moving forward to really have the greatest impact on reducing teen births and existing disparities. And we're using the data and results to identify areas in need of new and continued research and evaluation. So in terms of using data for continuous quality improvement, we collect, as Meredith had mentioned, a uniform set of performance measures across all of our grantees. And they include data on reach, fidelity, quality, attendance, and lots of other things. The grantees report that data to us every 6 months, and we spend a lot of time working with them on those 6-month intervals to review the data, identify strengths and weaknesses, and think about sort of improvements that can be made or enhancements that can be made. We also spend a lot of time working with them so that they are using the data in real time. So not just waiting for the 6-month intervals, but each cycle reviewing the data, giving real-time feedback to their facilitators to make continuous improvements. Our grantees also do process evaluation, looking at things like implementation, fit, satisfaction, staff training, and comfort, and are using that data as well in real time as they get it to make improvements and enhancements to their program. And just a couple of examples of how they're doing that. Our grantees have used their performance measure and process evaluation data to identify where adaptations are needed to programs. If they see, across many facilitators, they're unable to get through a certain lesson or the kids are not engaged in a particular lesson, that's an indication that some adaptations are needed to really enhance that program, make some adaptations. Or it can be an indication of poor fit. And so in some cases, they've used that data to identify where there's poor fit and need to select a different program. We've also used the data to identify needs for new recruitment and retention strategies. If dosage was low, figuring out kind of what additional strategies would be effective and then getting some feedback on if they were effective. And to identify additional training and technical assistance needs across all of our grantees at our program level, but also within individual grantee programs where they can see sort of is additional training needed for individual facilitators, or is it across all staff that additional training is needed, but this data has been really essential to kind of pull some of that out. And then the second way, we've used the evaluation results, both the evaluation results from our first cohort, in addition to all the evaluation that's been going on in the field in general, to inform the selection of evidence-based programs by our second cohort of grantees. So, for example, if there were any negative findings, which there were not many, maybe 1 or 2 had negative findings, but for moving forward, we've decided to be really conservative about that, and we are not allowing our new grantees to implement a program in the same way that showed negative findings. Until there's further evidence that shows something else, we've just decided we're not going to sort of repeat that was a red flag, and we're not going to allow that to happen again. For us also, we're taking, if there were 3 or more rigorous high-quality studies that were unable to replicate the findings from the first study of a program and there hasn't been sort of that same level of replication that shows positive results, we're taking that as a body of evidence, and we're working with grantees to really think about if there's a different program that would be a better fit for their community that has stronger evidence, and in that case, trying to go with the program with stronger evidence. If the evidence for a program is 20 years old or more, the program's actually being aged off of the TPP evidence review for HHS, and so our grantees are not implementing those programs. And then any new evidence-based programs that are added during the planning year, which includes programs from our first cohort of grantees, we identified 8 new evidence-based programs. Those are eligible to be replicated by our new cohort of grantees. So we're excited to be able to get some new programs, current programs out into the field. And then overall, we're really just working with grantees to sort of take this whole body of evidence and help interpret, figure out what it means and how they can use it to make selections in their community to identify programs that are the best fit. And just a note on that, we have found it's really important to translate evidence, especially for folks who are in programs trying to make decisions about how to use evidence to make program selections. Our experience has been, a lot of people will see a list of evidence-based programs and assume kind of everything on that list is the same, that as long as they pick something from that list, they're going to have outcomes. And at least for teen pregnancy prevention, there's 44 programs on the HHS evidence review, and they're incredibly diverse. They're incredibly diverse in terms of their approach, their dosage, sort of the setting, and also the outcomes, sort of the outcomes they were intended to impact, who they had outcomes for, how long they lasted. And so we have done a lot in our office and working with the Assistant Secretary for Planning and Evaluation to try to translate evidence and give communities more information so that they understand what the evidence really is. And we've done it in a lot of different ways. I'm not sure we've sort of found the magic bullet, but I think it's just important to keep that in mind. We've tried adding a lot more additional information to the implementation report so people understand what the programs are about. We've done interviews with developers, so for someone who doesn't want to read an implementation report, they can hear from the developer what the program is and what makes it work and what's exciting. We've done these sort of at-a-glance charts so you can see really easily differences across programs. We've just tried all sorts of different things, but I think it's important to think about translating evidence. And then we've used the lessons learned from our first cohort to actually redesign the teen pregnancy prevention program moving forward. So this slide shows you what the first cohort for us really looked like from 2010 to 2015. So in Tier 1, in our replication of EBIs, we were really focused, our grantees were primarily implementing 1 or 2 different evidence-based programs and making sure they implemented them well. And then in our Tier 2 research and demonstration program, we were rigorously evaluating either new approaches or significant adaptations to EBIs. And then also we tested a community-wide initiative in partnership with the CDC where the grantees were trying to have community-level impact, and they were doing things like implementing EBIs, but also looking at healthcare linkages, community mobilization, and sustainability. And so we had a lot of lessons learned and results from this first cohort. And so moving forward, this is actually what our replication of EBI's cohort 2 looks like. So one of the main changes is we've moved away from reliance on a single evidence-based program. What we're really looking for with our new cohort of grantees is implementing multiple evidence-based programs over the course of adolescence. So hopefully a young person would receive evidence-based programs at multiple times over the course of their adolescence. So something in middle school, something in high school, something in a clinic, something in the community, and that those programs would be reinforced. And then we've taken a lot of the lessons learned from our community-wide initiative that we did in Tier 2 originally in the first 5 years, and we're implementing evidence-based programs now in a much more holistic approach. So we're implementing evidence-based programs to scale, but we're also focused on community mobilization and engaging youth and families, making sure environments are safe and supportive, that all of our services are trauma-informed and inclusive, and that there's linkages to youth-friendly healthcare services. And through that, we still have a big focus on data, evaluation, sustainability, and dissemination. And then we realized that not everybody can implement evidence-based programs to scale, so we're also providing capacity building for those who are interested, but not yet at that level. And then in our Tier 2 program, our research and demonstration program, because the community-wide initiative was so successful the first 5 years, we've taken those lessons and applied them to all of our Tier 1 program. And so in Tier 2, we're focused on early innovation, things that are really good ideas but not yet ready for rigorous evaluation. They need additional time and support to get them ready to be able to do a rigorous evaluation. So we're focusing there. We're also doing rigorous evaluation of newer innovative approaches still, and we're really focused this next 5 years on filling gaps in the existing evidence base. And I've listed some of those on the slide. And then finally, we're using the evaluation and data to identify areas for additional research and evaluation. So this is just, the slide shows you some of the new evaluations that we have underway. We're doing a cost study to really get at and provide more information about what it actually costs to implement these evidence-based programs. There's not a lot of information out there about that, and we saw it as a gap that needed to be filled. And then we're doing a large-scale multi-site evaluation looking at the replication of commonly used but understudied EBIs. We still have a lot of evidence-based programs that are incredibly popular in the field, and they have a single study behind them. So we're trying to build a body of evidence for those programs. And then also looking at meaningful adaptations and core components, key activities, implementation strategies. So for us, things like implementing a program with teachers versus trained health educators, or implementing a program with a condom demonstration versus without, and trying to get some rigorous evidence for those types of different implementation strategies. We're also evaluating our new holistic approach for Tier 1 to really see if it's effective and if we can see community-level change. And we're doing a meta-analysis of all of the 41 evaluations that we supported, plus the evaluations that were supported by ACF the last 5 years, to really try to tell us what programs or contextual elements contribute to the positive outcomes. And with that, I will just say that there is a huge team that I'm representing that has been amazing in getting this program started and with the results that we've seen. So I just want to acknowledge all of the people that have supported this, and my contact information is there, and thank you.
There are so many things about this work that are exemplary that I hardly know where to start. There are just many things to note, to celebrate, and to emulate. And I'm going to list quite a few of them. So I want to note, both for the teen pregnancy prevention work and for CEO, the close integration of evaluation with government decision-making and with decision-making and practice by grantees who are service providers. I want to note that in both cases, evaluation is happening at multiple levels. There are local grantee-led evaluations, there are federally-led evaluations or city-led evaluations. 10 years ago, if you had asked me, and in fact people did ask me, I would have said and did say, no, don't build evaluation requirements into program grants. It's really not worth it. Grantees don't have the capacity. Many of them don't have this adequate sample size. The evaluations that emerge are going to be poor quality, and it's a waste of money. Well, it is the adolescent pregnancy prevention program that changed my mind about that by moving boldly ahead and showing that it can be done. And there are now several ACF programs that are taking similar approaches. As has been mentioned, in order to do it successfully, strong oversight and technical assistance is critical. But it can be done successfully, and I did not think that 10 years ago. So can add to the list of notable things that I changed my mind based on evidence. So I should maybe have started with this, but some very basic foundational things that we could take for granted, but really ought to be noted and celebrated. The Congress established the Adolescent Pregnancy Prevention Program as a tiered evidence program by reserving funds for models with evidence of effectiveness. And also, I don't know if you call it reserving, but the rest of the money was for innovation. Both of those are important. And as a result, there is now a careful, objective, sound, systematic evidence review in the area of teen pregnancy prevention. So we know a lot, and we know what we know because we have that systematic evidence review. Similarly, something foundational that we could take for granted is that CEO exists, and it has persisted across administrations. Some of us wondered whether that would happen, and apparently it did, so that is pretty exciting. And it is a model of a centralized yet collaborative approach to innovation and evaluation that I think is a model for other cities, also for federal departments. New York City, of course, is as large and complex as many nations, and certainly as many federal departments. So, so we shouldn't take that for granted. I also think it's notable to the extent that we've seen presented examples of using what we know to identify and address gaps in evidence for specific populations or specific settings or specific approaches. Also notable is the emphasis on examining not only the ultimate outcomes of interest, but also implementation and intermediate outcomes or pathways to those ultimate outcomes of interest. And something we heard both in the teen pregnancy presentations and from CEO was an emphasis on developing common metrics to enhance and amplify the usefulness of studies. With common metrics, you can compare, and you can conduct meta-analyses, and you can amplify what you're learning. Amy hinted at the extent of interagency collaboration in the federal teen pregnancy prevention practice and research and evaluation portfolios, and it's a very strong, ongoing, long-lasting collaboration at the federal level involving the Office of Adolescent Health, at ACF, both the Family and Youth Services Bureau and our Office of Planning, Research, and Evaluation, involving CDC and the Assistant Secretary for Planning and Evaluation. That's a lot of acronyms. It's a lot of different lines of authority, but they have persisted and maintained a really productive collaboration over many years. For teen pregnancy prevention in particular, it's notable that all of this rigorous evaluation and application of rigorous evaluation is happening in an area that involves not just sex, but teen sex. So this is an area where values and ideology and emotion can be intense. It is just really notable that the program and the research community and the grantees are investing in developing facts, bringing facts to bear. And I don't mean to suggest that values are irrelevant. They're very important, but it's critical to distinguish facts from values. So I could just say keep up the good work. I really think all of this work is extremely inspiring. I want to suggest that that the teen pregnancy arena and CEO's work are perhaps fertile territory for the kind of rapid, frequent, low-cost tactical experiments that Jim Manzi described yesterday. And I think Matthew mentioned that there is a New York City behavioral design team that is doing just that kind of work. And Amy described some of the ongoing continuous quality improvement efforts that have that similar rapid, iterative, real-time quality. But these are bodies of work where the relationships and the integration of evaluation with practice is already highly developed. And to me, that seems like a really great opportunity to take it even farther. So thanks to all of you. It was really uplifting to hear your presentations.
All right, so at this time, we have time for about 10 minutes for questions. There are 2 microphones in the room, and I'll also be checking. You can submit your questions via live stream. Hi to everyone in the interwebs. You can submit those questions, and they can be answered here. So I have one question on the left, one question on the right.
Okay, so regarding the teen pregnancy
I'm
prevention.
sorry, could you introduce yourself and
Oh,
your
sure.
affiliation?
Kevin Hamler-Dupois, I'm with the Oregon Department of Human Services. So regarding the teen pregnancy prevention, are there any plans to tie that in with involvement with public assistance and reduction of intergenerational poverty? Do you have any means for tying it to administrative data?
So I think the microphone over there doesn't work. We have been sharing the results and our lessons learned with folks working in child welfare and human services. I think there's a big push to try to figure out how to bring evidence to those fields. And then our grantees, our program is addressing sort of social determinants, and poverty and teen pregnancy are so linked. I'm not sure all of the evidence-based programs that we implement really do a good job of getting there, but it's definitely an interest, and we're trying. Sure.
Glenn Cuny from the Massachusetts Office of Inspector General. On the career-focused training, the sector-focused career training, how did you choose the sectors, and what assessment did you use to determine what sector a participant would be part of?
The criteria for the sectors initially was around trying to target high growth industries in New York City that also were able to provide sort of a pathway to living wages. So high growth, medium-ish wages. And then similarly, in the most recent expansion of the sector-based training, there's also a recognition that some industries are not known for being high wages, but they are permanent, and so it's thinking about how we can facilitate career advancement within those industries, including food service and retail. So we have industry partnerships now around technology, construction, healthcare, food retail, missing one. And particular to each of those industries, there's industry certifications and trainings that are relevant to employers, and the work of those intermediaries is to be partnering closely with the employers to understand which skills are most relevant to their needs and be driving the kinds of funding that we make to be towards those things that are most likely to be valued in the sector.
Question at the center.
I'm Kathy Tiarina, the Ridge Project, Ohio, and this question is for Amy. And so, as you were talking about the lessons learned and the expanding list of curriculum, so my question is, I guess 2 questions. One, can I find that list on your website? And the second one is, as you are approving additional curricula, is the standard of the, has to be more recent than 20 years and has to have a body of research instead of a single study? Is that applied to all of the curricula listed there, or that's kind of going forward?
So yes, you can get the link to the evidence review, and the programs that are on the evidence review is available through the OEH website. It's actually managed by the Assistant Secretary for Planning and Evaluation, but I don't know the website off the top of my head. So you can get there from HHS. What is our website? Just search for Office of Adolescent Health, and you can get to that list. But it's actually managed by our colleagues at the Office of Assistant Secretary for Planning and Evaluation. And then your second question about sort of what I was talking about for how we're using the results to inform program selection, those are actually decisions that have been made by our office working with our grantees. So, there's lots of other folks that are implementing the evidence-based programs, and they may or may not make the same decisions about sort of how to use the evaluation results to inform program selection. We've been trying to get all of the results from our studies out there, and we're doing a public release next week. So I think the evidence review has picked up all of the studies that we've done, and it's very clear, or it will be very clear once you look at the evidence review for each program, what the body of evidence is for the different programs. And then the 20-year question about if the evidence is 20 years or older, that's actually a criteria for the evidence review. So I think the evidence review will show sort of programs that had been identified as evidence-based in the past, but then are no longer sort of that have aged out. So you'll still be able to see them, but they've hit the 20-year window.
So we'll be able to see if there are multiple studies on the site.
Exactly.
Okay,
Yep, for each
wonderful.
program, each of the 44 programs, you'll be able to see all of the studies for each program and kind of what the evidence is for each study. Because a lot of it is mixed. So for individual programs, there's a lot of mixed data across studies.
All right, thank you.
Hi, I'm Martha Ross with Brookings, and this question is for Matthew. Can you talk about the process for integrating evidence into the agency budgeting process, and what were the successes and any bumps in the road?
Yep. I think this is the biggest area of growth or progress where we still need to make progress. I mean, typically, it's not as if evidence is absent or has been. The budget process is a local agency, Department of Youth and Community Development or Administration for Children's Services, develops a budget in connection with a deputy mayor that gets presented to the budget office. Ultimately, first deputy mayor or mayor signs off on those investments, and any proposal has to be accompanied by a rationale. So I think that's the standard approach. CEO has been in a privileged position to have the mandate to be focused on evidence, and so that typically we'll develop those new programs and partnerships with agencies anyway, but we'll have a heavy emphasis and it will be recognized that evidence is the driver for the proposal. I think there's a distinction though between the moment when a new initiative is proposed, which is often one that people have in mind there ought to be some rationale and what's the basis and so forth, and the sort of funding that just starts to exist over time. And so if we look across our multiple agencies on workforce, there's 7 different agencies and dozens maybe of different specific funding streams that are supporting workforce development or adult education or college success, are different pockets of programming that have just existed. And so the challenge for us is in the sort of reoccurring budget lines to embed a process that is get a little bit more scrutiny, and that particularly if new proposals are presented, there's a sense of, well, how will this compare with the results that we're getting elsewhere? And often we don't know what the results are that we're getting elsewhere. And so there's work for us to be able to look at the existing landscape and think about how to be more effective in tracking impact.
Well, if there's no more questions, I have a question I'd love to ask. This question about budget really, it is related to the question of, how do you interpret replication evidence and then make decisions that are sometimes hard decisions on phasing out programs and such. Amy, you talked about the fact that, well, if there's adverse outcomes, maybe we as a program office say, you can't replicate that. You made the statement, well, if there's 3 replications and and it's null findings, maybe we say we don't go forward. I understand that process for making decisions is often political, et cetera. I'm curious if you could talk about the different types of considerations that you thought about and the different types of considerations that you think about in deciding whether to recommend to phase something out.
Yeah, I think for us it's very difficult, right? The negative findings was easy, right? We were just, and it's not that you can't implement those programs, but you can't implement that program in the same way that it found a negative result. And we've said until evidence shows us something different. But if something was sort of doing the opposite of what we were hoping it would do, we just can't do that. So that was easy for us. But where the evidence is mixed, it was very hard and it's very subjective. The 3 or more, that's just all we have at this point. We don't have anything with more than 3, so we just sort of picked that as a limit. But we felt like we were seeing sort of all of this evidence come and what it was showing us, and we had to do something with it. So we may not have made the right decisions, but we just decided we were committed to using the evidence moving forward and not just doing the evaluations and then continuing to repeat all of the same things. So that was how we decided. And I think we're just committed to using data and results. And so it was hard to sort of pick the lines of where to make those decisions, but the idea that we had to make those decisions was just a natural one.
Mm-hmm. Yeah, and I'd acknowledge the difficulty I think everyone recognizes that. I think one of the pieces of research we've talked about coming out with is exactly that process of discontinuing programs that don't show results. I think some of the considerations that go in is, so take the hardest case, something that's like not doing that well. And usually, again, I think we all would recognize it's not clear necessarily black and white, this was great, this didn't work at all. There's always some often mixed findings. So some considerations that would come into play is, are there alternatives for this program model, for this population, for a particularly difficult population? Do we know, how does it compare favorably? Even if we can't do a common metrics comparison, what's the landscape of our funding environment for a particularly vulnerable population? Can we acknowledge that there were implementation issues? So yes, it didn't get the results that we wanted. Is that a model problem? Is it a provider problem? Is it a funding amount problem? So trying to weigh those factors. I think you know, the advantage, I think, of contracts sometimes can be that they have a natural end date. So it'd be like a 3-year contract for potential renewal. And so that, you know, that's often a natural point to try something different. And then I would say the other, you know, within an environment where every funding stream has a constituency once the funding stream exists, we found it's easier to repurpose existing dollars towards a similar challenge within the same agency than to simply pull back the dollars entirely. So if something's not working, we try to work collaboratively to find sort of redesign.
Yeah, can I just add to that? Because we've done the same thing. Nobody's losing their funding. It's just about helping select programs that are a better fit. And so I think that takes some of the pressure off. Although the interesting thing, the more and more we've worked with organizations to interpret evidence and use evidence, it's very easy for folks to get confused. And so we've had a lot of people come back to us, well, I found this study over here, and it says, you know, that they didn't find findings, so we can't do this program either. And so for us, it's been very important to stress we're not making decisions from a single study, but it's really a body of evidence. And so again, you know, the 3 or more is kind of what we picked just because that's what our body is. But I think there, you know, then there was confusion about kind of individual studies and kind of, do we need to move or do we not need to move? And then, you know, program developers and sort of working with them, you know, to explain the replication evaluations don't mean their original evaluation was wrong. But, you know, things change, and as you take them, it was important to reiterate, we implemented programs and evaluated them in new settings with new populations. And so, you know, they have concern. It's their sort of life work in some cases, and so I think it can be really, really touchy.
Thanks. All right, I think that does it. Anything else? All right, have wonderful days. See you at the next session.